Kathleen, thank you very much. Actually, thank you, organizers, scientific committee members, and chairmen for this event. It's actually a very interesting topic, and I think we will talk about this in a little bit more details. So if we look at my disclosures, so lecture and workshop fees from both companies, Johnson & Johnson and Medtronic, but nothing to do with this presentation. And everything started about 10 years ago. We had a very nice European Obesity Academy project. Some of you have been actually in this project. It's a project that went 10 years, financed by Johnson & Johnson company, and a lot of current opinion leaders were there. And here you see it's also the product of this academy, and it's Ido, Guy, Piri, and me in London, and we presented actually first inventory of access to metabolic surgery across Europe. It was published in 21, but the data were collected 2016, 2017. Why it's relevant? Because I tried also this time when I got the topic to update these data, so I sent again messages to the experts, and it's pretty recently to this Congress, and I asked three main questions about waiting time to metabolic bariatric surgery, private and public hospitals, how these experts rate the access, poor, fair, or good, to bariatric surgery, metabolic, and about GLPs. Have they reduced the number of the procedures? So there's a large number of experts that have responded and have been included, and I think we'll go forward on with doing a publication on this. So we had 32 countries. And the countries that were missing, still I think some of them is present here in this conference, so I'll try to collect some data, but majority and the main countries were there. So how look the data currently is that if we looked at the reimbursement of bariatric surgery and waiting time in public and private, so no reimbursement still there is in some countries across the Europe. Serbia said to me, no, we have reimbursement, but actually the state reimburses only to 40 to 60 procedures per year, so we can ask if it's really the reimbursement. So, but in European Union, we have Latvia and we have Romania, but also there is Hungary and Bulgaria where there is no reimbursement still for bariatric surgery. But reimbursement is one side, but the other side is the access. What is the waiting time in the public hospitals? And here we see that we have the countries that are reimbursing, but like Ireland, the waiting time is from 2 to 5 years. And then there is Portugal, Spain, UK, main countries also with a long waiting time. So the other countries are in a reasonable range because even those in the yellow that said up to 1 year, so here is included, this still you can ask yourself what is a waiting time, because this is time which includes also preparation programs, because preparation programs can be up to 6 months. And majority says that after these preparation programs, or if there is no preparation program, still a majority of countries, the waiting time is from 3 to 6 months. And I think it's quite reasonable, except of those 4 countries that I mentioned. In the private, for sure, there is no waiting time, except also Ireland, where they have up to 3 to 9 months. But in the other countries, few countries like Croatia and Slovenia, they are not doing bariatric surgeries in private at all. But in the other countries, it's like from few weeks to 1-2 months. So, and if we look at the access, how the experts have rated the access to bariatric surgery, one thing I can say, you see the graph of the circles, and in the middle, circle is how they rated in 2016 and how it's rated in 2026. I can say that good and fair access right now, there is about 60% of experts or the countries rate access like this, while 10 years ago, it was only maybe half of this, like 35% of experts rated is good and excellent. But also still, we have to ask what our experts are rating as a good. Because, for instance, in Ukraine, there is no reimbursement of bariatric surgery, and still we say that the access is good. So maybe this is also still we have to define a little bit better what we mean by good access, because if we look at the Romania that also has no reimbursement, the rate is as poor. But also Ireland, the only country that has not improved the rating, and like 10 years ago it was very poor, and now currently 2026 is also very poor. So now the question is about GLP-1 analogs and modern medications, obesity medications. So how these medications has affected bariatric surgery. One thing I have to say ahead of comment of this slide is that only few countries in the Europe are reimbursing GLP-1 analogs for their patients, and this is actually Switzerland that is currently reimbursing up to 3 years. But if we look at the Switzerland, even reimbursement does not affect metabolic surgery rate. And the other country is Austria, where they reimburse for those who are preparing to bariatric surgery, they reimburse 1 year GLP-1 analogs. But in all other countries, there is no reimbursement except for diabetic patients, Ozempic, as we all know. But if we look, and this is in a public, yes, in a public we can state right now that in 2026, all these medications that we have, they either do not reduce or mildly reduce the numbers of bariatric surgeries. There are exceptional few countries like Georgia, Greece, and Sweden, Slovenia, Kazakhstan, where we have reduction by about 30%. But interesting is what's happening in the private practices. Not everybody, actually these experts, majority of these experts were working in the public system, so they could not provide good data on the private, but those who were able to provide, so we see that reduction in the number of private procedures ranged from 10% in Estonia up to 70% in UK. But also interestingly, there were a few countries that provided data on the medical tourism. Actually, one of countries is Lithuania, because we are having quite a number of medical tourists, Latvia also, and Turkey. So in Turkey, they see right now decrease about in 25% of medical tourism bariatric surgeries. In Lithuania, about 50%, but in Latvia, up to 90%. So major limitations of this, my study or short presentation, is that actually I looked at the expert opinion, and it's a surrogate estimate how access to bariatric surgery should be measured, because there are a lot of points like timeliness, affordability, equity, acceptability that we actually have not accounted in this study. But in summary, I would say that about 69% of European countries, the patients are waiting up to 6 months for MBC, and about 60% of experts are rating access as good and excellent, and availability of medications decreased only slightly or no decrease in public hospitals of bariatric surgery, but there was in the private system, there is a quite substantial decrease. But the other question is still an access of the patients to the bariatric surgeries in different places of the Europe. Here we have actually Medtronic is doing like expert meetings in Central European Europe, in Central and Eastern European, but to see how we can improve access. But the problem with Medtronic, a company that is private company looking at these things, is that there is no credibility. So still, if we look at the whole Europe as a whole, we see that we have problems with an access in Eastern and Central European. We have even in the South Europe, like Spain, Portugal. We have in UK, Ireland. So I would say that the time has come to look for, or call to action, for establishing like task force within IFSO to monitor access and to improve access, to help for the societies to look in this more deeper, what problems they are getting and helping to manage these problems. So thank you very much.
Yeah, thank you very much for your talk. At least from our chapter point of view, or IFSO point of view, we got the privilege of having the president of IFSO here with us. Thank you very much being here. At least to more accurately looking at the phenomenon, because first of all, we need to understand, and then maybe we will suggest in which direction to act. But nowadays, you collected, and thank you very much. I think it's interesting, which is the situation all over Europe. If there are any questions.
I have a question to you. We had a SECO part meeting with the Spanish Health Ministry a few weeks ago in order to improve the access to bariatric surgery for Spanish population. And we bring into the table the fact that Italy has recognized obesity as a disease by law. Do you know if this situation had any kind of impact in the evolution of the access of surgery to bariatric surgery in Italy? And do you know if there's any other country in Europe that is going in this direction?
Actually, you are completely right. If you look 2016, 2026, 2016, Italy had rated as very poor access to bariatric surgery. Now they are rating as a very good. And I talked with Italian surgeons, and they said that in the public and also the private hospitals, they are financed by the public system for doing bariatric surgeries. So now they increase significantly. So recognizing obesity by, as you said, by law. I don't know what it actually means, because World Health Organization recognized obesity as a disease. So what else we need to, I mean, should we go to the ministries and say, look, put it as a law? No. I think that there are a lot of what we have to do to recognize the barriers to bariatric surgery. And one of the barriers is healthcare system. Yes, not taking everything like patient thoughts and so on, but healthcare system. And we have to work in a systematic way. What I can say, for instance, when you are going as a local society, that's good. But if you get also support and endorsement from big society like IFSO, I think it will be quite different value when the people will be sitting with you and talking with the government. We talked with Katalin today in the morning. I had been fighting in Lithuania 17 years to get reimbursed bariatric surgery fully, because they have been in reimbursing only stay in the hospital. They have not been reimbursing single-use instruments. And it has taken for me 10 years. I have finished London School of Economics and became a master to do and go to politics, to do health economics evaluation and put on the table. And only then they recognized this. So there are different ways, but I mean, that's why I'm taking this point of the task force, because still you see Spain, Ireland, a lot of countries that we think we have reimbursement, but reimbursement is not everything. We have to see how we have to improve the access. And this is, we have to look in more systematic way, and to take into account policy actions that we as a society have to take or support local societies.
I have to say that the answer was no.
Yes,
Yeah.
for sure.
Yeah.
Why?
Okay.
Why?
Yeah.
Because you have to prove.
Yeah.
Yeah. But we need to go on, and also in this session. But with this task, I think it's very important to continue. And maybe we should address at a different level, because at least in Europe, there is a European Union, and it's supposed that each European Union citizen would have same access no matter the country is living in. So that means that there will not be differences, disparities between citizens. So it should be addressed at the highest level at the EU. But it's very well taken, and now we got the privilege to invite Cynthia Burg, and she is responsible for the multinational committee, exactly the right moment you address the call. And probably inside that committee, it should be organized a task force looking exactly to the problem, and then we will see how it will be addressed. Thank you very much again. Cynthia.
Thank you very much for the invitation and for the kind introduction. So, I was asked to talk about what drives European patients to bariatric surgery tourism. I don't have any disclosures. So we definitely have a problem in Europe with the high prevalence of overweight and obesity, with at least half of our population suffering from either condition. To date, we know that surgery is the most cost-effective treatment for patients with severe obesity, and an increasing number of our patients are choosing to travel abroad for treatment. Bariatric tourism accounts for about 2% of bariatric procedures performed worldwide, and they also account for 20% of cases of medical tourism. So for the providers of medical tourism, it is a very important industry, because at least 1/5 of the cases depends on bariatric patients traveling for bariatric surgery. It's usually bundled as a package with accommodation, transport, and some degree of post-op care. And it's usually self-funded. Now, when I started doing my research about this question that I was tasked to answer today, there was very, very little in the literature about what actually made patients travel abroad. There were several opinions, there were several papers talking about the risks, as though none of our patients have ever had leaks. So if a patient has had bariatric tourism and has a leak, it's worth a publication. But of course, I'm being sarcastic there. There are lots of opinion pieces on how we can make it better, but in terms of finding why patients are traveling, there was only one small Canadian study that actually went and asked patients. So I had to have put my thinking hat on and think, the patients that I've seen, both in the UK and in Malta, why did they choose to travel? So I said, let me think about the domestic services that I know about, the British NHS and the Maltese Public Health Service. So currently, and I'm sure that this is not just the two places I work in, but across Europe, there is lots of diversion of public health care funding being under pressure, being diverted to things like defense, which I'm not saying is not important, but the healthcare budget obviously is not increasing. And there's also a decrease of manpower since probably the pandemic. We are currently only able to cater for 0.1 to 1% of the need. At least in the UK, there's very patchy geographic availability, with certain big cities having several centers, but then, several large regions with no services at all. Unfortunately, our managers and some of us have created very complicated, inflexible and costly pathways with lots of duplication between the different tiers, between the medical pathways, the sort of dietetic pathways and the surgical pathways, resulting in very long waiting lists, and obviously our demand is exceeding the care capacity. So thinking about the first driver, the patients are asking for timely solutions. While we're here debating on definitions of obesity and whether a patient has clinical obesity and whether they should be treated as priority or not, it's our patients that are suffering from decreased quality of life, and it's our patients that are suffering from their medical problems. So we have seen the lovely previous presentation, but at least in my experience, in the two places that I work, there are waiting times of between 1 to 3 years in the public healthcare systems, and patients get disengaged while they're waiting. They do a psychological problem, and then they have to wait a year, 2 years, 3 years, and they get discouraged. And one of the quotes that I found in this Canadian papers, I don't have to prove to anybody that I was a good candidate for surgery. I know that I'm a good candidate. I am convinced that I need this surgery. The second key driver is cost differences. That's why some patients are traveling at least. There's lack of insurance coverage in Europe, and surgery abroad can be 50 to 70% cheaper than our domestic private healthcare systems, be it lower costs of labor, higher volume, competitive markets, and some differences in standards, then, that account for those costs. However, cost is rarely the sole motivator that these patients are getting to travel. Oops, sorry, I must have them. Sorry, have I lost any slides there? No? Okay, something must have happened there. Okay, there's certainly a difference in perceived quality of care, and the patients are being marketed on social media and seeing, these lovely bespoke facilities that are available elsewhere and that are not available in their countries. Sorry, I must have... There's also the convenience of having all-inclusive offers and the coordinator. And anyone who tried to actually contact a bariatric surgical secretary, in the UK or even in any place, I bet you stay running around for about half an hour till you actually give up. So simplifying the patient journey is very important. There are obviously risks that we know about, the possible risks of early complications, communication barrier, follow-up care, and the pressure on domestic healthcare systems if those happen. And I once again get this plea to you. This is the poster that we did about emergency surgical care. Obviously, these patients won't see you as the first port of call because they're not in your healthcare system. They might come to your emergency services, they might go to your GPs. So please, if you do have any contacts with your emergency doctors or your general practitioners, please highlight this to them. So future trends, I think there will continue to be a growth of medical tourism, especially if patients sort of do the maths right now and say, listen, the OMMs are costly, I could get this done and dusted. There might be some increasing regulation at EU level, and hopefully by the expansion of telemedicine and wearables, follow-up care for these patients who have had surgery abroad will become easier. So bariatric tourism reflects the gaps in our domestic healthcare systems, and unless there are changes, we are going to continue seeing patients opting for surgery abroad. We need to design our pathways with the patient in the center, with the patients, with the multidisciplinary care team, to ensure that they're simple to navigate, safe, and cost-effective. Thank you.
Thank you very much. If I may propose to you, because all the lectures are referring to medical tourism, to invite the other speakers to speak about the topic, and then we will have discussion on this respect. Please make some notes for the questions you would like to address. The faculty will be here to answer to you.
Thank you. Okay, the next talk is about clinical experience, quality and patient safety in metabolic and bariatric surgery. Tourism from France.
If you
Yes.
couldn't
Yes.
make it.
You can introduce yourself, please.
Yeah. Thank you. So I'm Dr. Saad Jouma. I'm a consultant surgeon with Professor Nokka in Montpellier. He sent you his excuses. He couldn't make it, so he just told me yesterday to prepare that talk. So today it's a new topic for me, but it's very interesting, and I found lots of good things
We
about
hope
this.
we will not notice that you prepared yesterday.
No, you will see. So this is the fight. So today I will talk. Today we will talk about the bariatric tourism, and especially we will talk about the quality and the patient safety, because all of us, especially in France, we received many patients operated upward, especially coming from Turkey or Tunisia or Northern Africa. And these patients sometimes come to us with some complications, maybe lack of follow-up or weight regain. So we have to take them in charge. Why bariatric and metabolic surgery tourism is so frequent these days? There's many reasons. The first one is that we have a very long waiting list period in France and in whole Europe. For example, in France, we have at least 1 to 3 years waiting list before doing the surgery, including the pathway when we start the first consultation. And in some countries, it can goes up, like in Ireland, between 2 to 5 years. The second cause is the cost issue, because I will show you in the next slide the cost of the sleeve gastrectomy in different countries. And we can see that in some countries, the prices are really 3 times, 4 times less expensive than Europe or North America. The third cause is the limitation of the indication. So because, as we know, in some countries, in Europe especially, we have a threshold of BMI. For example, in France, a patient with 39 of BMI with no comorbidities, he does not fit the criteria to do a metabolic bariatric surgery. So some of these patients will go around to do this kind of surgery. And the final cause that we can find is the surgical skills, because some patients go to another countries just for the reputation for the surgeon or that specific hospital. Here, we ask the patient what are the reasons to do bariatric surgery abroad, and the main reason was the low cost of the bariatric surgery. We see that 77% of the patient goes abroad because it's less expensive. Some other patients goes there because they have high quality care. 40% says they go because they have long waiting list, and some patients, for example, they just go to be operated upward because they have family, they have friends and support in that country. This is what I was saying. As you can see, the prices of a sleeve gastrectomy, the different prices. As you can see, for example, in United States and Canada, the average is between 16 to 18,000 US dollars. As in Europe, for example, the average is around 15,000 euros. And you can see Iran, for example, it's 4,000 euros. In Costa Rica, it's 7,000 euros. In Mexico, it's almost the same. So the prices are really different. So it's 3 times, 4 times more expensive in these countries. In the literature, as my colleague said before, we don't have lots of literature, but I found this consensus that was published in 2023 in Mexico and published in Obesity Surgery. That was the first national consensus of the safety practice of the medical tourism in bariatric surgery. So in this article, they had 32 bariatric surgeons, experienced bariatric surgeons in Mexico, and they discussed about 52 statements, and they had a consensus of 76% of these statements to do like a rule of safety for the patient who's going to be operated upward. Another paper published also in 2023 in London in BBC, and that was a shocking story for in England, where they talked about 7 patients died after bariatric surgery in Turkey. So Dr. Ahmed, one of the surgeons in the NHS, I think, hospital in London, talked because he had follow-up for these patients, and he found that many patients had an entirely different operation of the one they understood they paid the price of. So some patient came to him, for example, doing sleeve gastrectomy, and they realized it was just a gastric plication, or the patient paid for a Roux-en-Y gastric bypass. At the end, it was a sleeve gastrectomy. So we really had that lake of information. And if you can do some calculation, he was a little bit surprised, because the cost of a bariatric surgery, for example, a sleeve gastrectomy, if you want to take in charge the cartridges, the energy, it will cost at least 3,000 euros, between 2,000 and 3,000 euros. And in some countries, they are offering the surgery with the hotels and everything for a package of 2,500 euros. So this is the main problem. So what are the risks that the patient will have after this kind of surgeries aboard? Mainly, it's the poor quality of post-operative care. As we can see here, 85% of these patients, they don't have any post-operative follow-up. And we all know that the bariatric surgery patients, we have to do a lifelong follow-up with them to manage if they have any problems, any reflux, any deficiency. Another number is 75% of these patients are not even aware of post-operative supplementation. We have a higher risk of complication, mortality, morbidity, and we have also 35% of patients that they don't have a very good results. So they have poor overall result after this kind of surgery. So what is the solution? Professor Nocca, he's working since 2 years on something he's managing called the virtual clinic. And in this virtual clinic, we started in Montpellier this year. We made a website and we give access to all the patients. And in this website, it's called Mediland, the virtual clinic. And with this access, every patient can go to the internet, put his code, and he will do a virtual tour where he will see the surgeon. He will have a video of like 10 minutes with the anesthesiologist, the dietitian, the psychologist, and at the end of these small videos, all the patients has between 50 to 70 questions, and the patient won't have the certificate that he passed this virtual clinic unless he will validate all the right questions. So maybe that can be a great tool to have this certificate for patients who's gonna be operated upward, to make sure that they understood what is the pre-operative care, the per-operative and the post-operative care and follow-up of these patients. So to finish my presentation, what is the most important take-home message of this talk is that we have to concentrate on the safety of the patient. So the patient, we have to treat it well, even if he was operated in France, in America, or elsewhere. The most important thing is the safety of the patient. We have to improve the follow-up, even if we received patient operated upward, we have to improve the follow-up and take care of these patients. And especially we have maybe to do some accredited programs for these hospitals or clinics that will receive our patients from Europe or North America, for example. I think that we have to get like a system who said these hospitals or these clinics are capable of operating these patients, avoid bad publicity and bad talks between surgeons and hospitals, and finally make a good organization of bariatric tourism and increase the collaboration between hospitals in France, in Europe, in North America, North Africa, and all the countries. So that's it, and thanks a lot. And we are waiting for you in the IFSO next year in Paris with Professor Patou and Professor Nonka. Thank you.
Okay, thank you.
You may take a seat, please.
Thank you.
It's my pleasure to present Dr. Asunción Acosta from Spain, Ethical and Social Implications of Metabolic Bariatric Surgery Tourism.
Good afternoon. First of all, I want to thank the organizers because of this kind invitation to be a speaker in so interesting session. I'm going to talk about ethical and social implications in bariatric and metabolic surgery, medical tourism, BMT. Well, the definition you know, people traveling abroad to access bariatric and metabolic surgery for reasons of accessibility, cost, waiting list, or anonymity. Really, the medical tourism is an old practice, as you know, and the medical tourism industry is valued over $400 billion annually, and bariatric and metabolic surgery is one of the leading areas within medical tourism that is increasing in Europe and represents more than 2% of global bariatric and metabolic surgery. That is annually growth approximately 25%. The 5 main countries of origin are USA, Germany, United Kingdom, Saudi Arabia, and Canada, and Europe acts as both a sending region and a receiving region. The sleeve gastrectomy is the most frequently performed procedure. Some concern relating this is emergency issues in BMT. Increasing concern remains allergy unregulated, lack of structural treatment, post-operative follow-up, and so on. We are going to debate it. But first of all, I want to analyze, like the previous speaker, some barriers and contributing factors in bariatric and metabolic surgery. First of all, of course, we saw it before, the availability, the long waiting list in the local healthcare system, and the limited access of the local bariatric surgery service in the country of origin, with restricted access to bariatric and surgery due to lack of indication and referral by the primary care physician. The financial cost, the lower cost of distant healthcare system and local one we talked before, and the strict criteria for BMS of the local level. Also, the global recognition of the healthcare system with reputation different, and the social stigma because negative perception and lack of support from general practitioners to refer for the bariatric surgery. The predominant mode, if you know, is in all-inclusive surgery packages with surgery plus hotel plus transportation, with an early post-operative discharge and post-operative follow-up delegated to the healthcare system of the patient's country of origin. So if we analyze the websites offering BMT services, we now identified some significant deficiency in accreditation, physician-patient communication, perioperative care, and travel-related health advice. For example, if you know the medical notes of the patient are less than 2.9%. Another papers related to this can see highly variable cost, as you said before, and poor psychological assessment on dietary assessment with an aggressive digital marketing strategies with travelist purchase and financial incentives, and early booking discounts, and so on, with ethical concerns regarding incentives and deviation from the international patient selection criteria. There are very limited provision of travel health advice, for example, thromboprophylaxis for long-haul flights, and the lack of transparent information on clinical outcomes and complications, with ethical and legal implications, of course. Information predominantly focuses on positive patient experience, with negative outcomes largely omitted. As we see before, using the PARMA papers in 2021, this survey showed that significant difference in cost per procedure. For example, in the USA, you can be operated by about $15,000 or $20,000, but if you go to Turkey, you can be less than $5,000. And like the previous speaker showed in this, this is important because the main motivation for BMT is really the low cost, with surgeries up to 80% cheaper than in the country of origin, on long waiting lists with motivation factors. So I wonder if the reasons for bariatric tourism reflects system failures in access to bariatric surgery rather than simply individual patient choice, like previous speaker pointed out. Also, we identified in this systematic review that important deviation from international guidelines. So this is the increasing of risk of fragmented care with lack of continuity of care that may delay diagnosis and treatment of postoperative complications, increased emergency department visits following surgery abroad, and limited access to medical records of operative reports, with increased burden and costs for the healthcare system on the country of origin. So this is the same because we have some papers, important papers we have to point it out. And if you ask to the surgeons, they perceive a higher postoperative risk following BMT. As you see, poor education, poor quality of postoperative care, higher mortality, reoperation and complication rate. And also there are some systematic reviews that report higher complication rates up to 56% in medical surgical tourism related to infections, anesthetic and functional outcomes, adverse cardiovascular events, or deep vein thrombosis, particularly in obesity patients. So ethical and moral concern rises around BMT. Also, if we have in this global survey, the surgeons think that, believe that patients should be held responsible for their complication if they go out to submit it to operation. More than 30% surgeons feeling uncomfortable managing patients with complication from other centers, as you know. So some key ethical questions emerge. Because can bariatric and metabolic surgery be considered ethical if it's technically correct but fails the postoperative follow-up? Can we trust indications, protocols, and bariatric techniques performed outside the frameworks of international societies? And is the patient truly able to make an informed consent with language barrier, etc.? So we think that they are broken the ethical framework related to the classical principles of autonomy, beneficence, and justice. Regarding autonomy and informed consent, we wonder if is consent truly informed, incomplete information provided regarding risk, follow-up, and likelihood of complication. This IFSO global survey from PARMA et al. Answered that more than 30% of responders consider informed consent in BMT inappropriate. So there are also some limitation of the autonomy of the patients in BMT, with a deficit information with language barrier, minimization of risks, and lack of information on postoperative follow-up, with decisions influenced by patient vulnerability, obesity-related stigma, and economic pressure. So autonomy without full information is limited and ultimately illusory. Also, the principle of beneficence is broken because it's technically correct surgery without comprehensive treatment. Well, the proper surgical technique alone does not guarantee optimal clinical outcomes when continuity of care and complication management are lacking. Absence of follow-up constitutes a form of ethical malfeasance, I think. And we transfer the risk to the healthcare system of the country of origin. So harm does not occur on the operating room. Sometimes often occurs afterwards. Also, the justice and equity are broken because the use of public resources to treat complications of privately funded surgery abroad. And only those who can pay can access surgery, but yet everyone finances the complications. Is a model that privatizes benefits and socializes risk ethically acceptable? So there are some social and professional implications, as you see. For the patient, fragmentation of care, unrealistic expectation, stigma, for the surgeons of the country of origin, management of complication without care, operative information, professional burnout, and also for the profession with the risk of commodification of bariatric surgery. As previous speaker said, Rodriguez et al. Published the first national consensus of safe practice of bariatric and medical tourism in Mexico, but it was a promising step forward, although the majority of participant surgeons were BMT providers and potential risk of outcome bias. Posteriorly, and others pointing out the need of transnational regulation to protect the patient of the healthcare system and the important role of the scientific societies, which promote the accreditation of centers, continuity of care requirements, mandatory post-operative follow-up on the country, and also the transparency of the outcomes. So, if so, and the rest of the societies have some proposal regarding European registered ethical requirements for bariatric surgery advertisement, mandatory continuity of care protocols, and cross-country cooperation. Some key messages in this paper was published in 2021, but today we have the first European consensus on safe BMT practices in 2025 with consensus recommendation covering all phases of
You got some
BMT.
water on your left.
Thank you.
Okay. Put it back. Okay. Okay. Take your time.
Thank you, sorry. What's to finish two slides. These recommendations covering all phases of BMT, pre, peri, and postoperative care, with comprehensive preoperative evaluation regarding psychological, nutritional, cardiovascular, respiratory, and hepatic, the accreditation of the surgeons, countries, and the centers and techniques, and standardized patient education. Also, an important point, with mandatory multidisciplinary follow-up at least 2 years, and safe-related recommendation, for example, remain near the surgical center for at least 5 postoperative days, and extended thromboprophylaxis up to 4 weeks. So, to finish, this is not about criminalizing the patients or ignoring the reality. It's about regulating, protecting, and ensuring quality and continuity of care. Because bariatric and metabolic surgery must be ethical, not only in the surgical act, but throughout the entire continuum of care. So my conclusions are that bariatric and metabolic tourism is associated with relevant clinical risks and it raises significant ethical dilemmas related to autonomy, beneficence, and justice. Without regulation, both patients and healthcare systems are exposed to avoidable harm, and solutions require transnational cooperation and robust ethical and scientific standards. IFSO and other scientific societies play a key role in leading global standards because obesity is a chronic disease and bariatric and metabolic surgery requires continuity of care. Treatment as a fast consumption product is ethically unacceptable. Thank you for your attention.
Thank you very much. We invite you to take a seat because we decided earlier that we will have very nice discussions and you will be able to answer to the questions that obviously will be addressed. And we will continue on the topic with a very important talk that it will be offered by our president. Khalid, please. We have the honor and privilege to have with us the president of IFSO. And he is going to talk about the IFSO MENAC and the IFSO global perspective of metabolic and bariatric surgery tourism. Because your area is really providing a lot of content, may I say, on the topic. They are very active centers, and we will see where is exactly the reality. We will balance at the end which is responsible for all the problems and how guilty they are, meaning they in our countries, in the other countries, or the patients. We will see that's very complex. It's becoming very complex. Khalid, please.
Thank you, Catalina. If you think you heard enough bad things about medical tourism, no, you haven't heard anything.
I am not convinced enough.
Just wait.
Okay.
So this is with Antonio, King of Spain. So these are my disclosures. This is my case mix disclosure. I don't think it's relevant to this speech. 70% of my practice is revisions. So we do not have risk-free treatments. Make sure the benefit outweigh the risks. And you know, when everybody believes they are the good guys and those who differ are the bad ones, and no one on the bad guy's side feels they are doing anything wrong. And it's not hard to do the right thing. It's just hard to know what the right thing is. All bariatric procedures will give some weight loss initially in the first 18 months, the honeymoon. And all bariatric procedures will show weight gain after that, so results for 5 to 10 years later are completely different from your initial results. And regarding the conflict of interest, the conflict of interest in medical practice arises when a surgeon entrusted with acting on the interest of a patient also has financial, professional, or personal interests or relationships with third parties, and which may affect the care of the patient. And you know, George Bernard Shaw in 1906, he's a Nobel Prize winner, he made a nice play, it's called The Doctor's Dilemma. And he said that private medical practice can sometimes be administered by licensed, ignorant murderers. So what are the current styles? I'm especially referring to what we have in the MENA region. What are the current bariatric surgery practice styles? We have the scientific bariatric surgery, which is evidence-based, logic, university setting, no financial implication, no confirmation bias, so what the patient needs as a treatment. And we have the commercial bariatric surgery. Give me the money, regardless. So if you got the money, I'll take it, and then we can discuss the details, what the patient can afford regardless of his needs. Like MGB was sold as a better operation than Roux-en-Y gastric bypass in 1998 by Rutledge. He didn't even do any comparisons. He never compared them, but this was a selling point. And you know, when money speaks, no one checks the grammar. So we also witnessed in the Middle East, started in Jordan, the bariatric surgery industrial design explosion and the rise of medical tourism. So we have out-of-pocket surgery, so patients will search for the best bargain, not the best surgeon. And they go into price wars, so they re-sterilize the single-use equipment. And in Egypt, we see $400 sleeves. I've seen much better prices here before. Low cost, 20 to 40 sleeves per day for a surgeon. No pre-operative care, no post-operative care, there's no time for that. And re-sterilized single-use equipment is the rule. And you use very low-quality smuggled stapler loads that come from China, unsterilized. And to have safe volume like this, you need to modify your operation. So the relaxed sleeve concept came along. So you do a relaxed sleeve, less complications, less cost, and less weight loss, of course. And even with zero follow-up, you can see publications of 5 and 6 years follow-up for these surgeons when they never followed up their patients. And everything here is recyclable and reusable, including the patients themselves. These are soft drink factory techniques where we care about unit numbers rather than true human care. And you know, the perfect deception in bariatric surgery, when you have an easy procedure, every procedure will give you some short-term success, but on the long term, who cares? And if the patient fails, just blame the patient. Tell him you're my only failure. All my other patients have worked with them. And with medical tourism, you're not accountable for your outcomes. Patients have the surgery, go elsewhere. So what are the concerns with medical tourism? We have substandard care, mass production techniques, and we have complications and how to manage the complications. And patients follow up, as we heard before. Patients have zero follow-up. And procedure outcome with substandard techniques are completely different from the regular outcomes. And you know, we also, in bariatric surgery, we have terminology pitfalls. So when you have somebody calling an operation a mini gastric bypass, it's the little bypass, it's not the big bypass. That's why in IFSO, it's not allowed to say MGB anymore, it's OAGB. And also when you do an endoscopic plication, and just call it endoscopic sleeve, because plication is not good, sleeve is good. At the end, if you attach bowel to stomach, it's called a bypass. So whatever operation you have, if you attach some bowel to a stomach, it's called a bypass. Which bypass? Which outcome? So what's really happening? So the typical patient, this is a typical conversation for medical tourism. So the patient says, how much is your sleeve? 500? No, make it 400. Okay, book me for tomorrow. Okay, what's your name again? That's the medical care they give. So we have substandard surgical care, reuse single equipment and counterfeit staple cartridges, relaxed sleeves, less problematic, and the setting, very high failure rate. We have quick in, quick out, so that even if you have a leak, you can have it in your country. Your country should pay the $100,000 fees for treating your leak, but we're not going to pay it, okay? And this is a sad picture. This is a patient I received in my clinic 1 month after having a plication, a gastric plication. So this is what happens, no care. Also, the new and experimental procedures, they are widespread in medical tourism as standard procedures. So where are now the ethics and institutional review boards and IRB protocols that are supposed to be there with these procedures? You know, a lie often told becomes truth. Beware of false knowledge. It's more dangerous than ignorance. So what happens when you have bariatric surgery with poor data quality? Garbage in, garbage out. Low quality data produces low quality statistical analysis. And you know, if you don't read the newspaper, you are uninformed. But if you read the newspaper, you are misinformed. So we had a position statement on innovative procedures, and some of these procedures are still considered experimental, namely the bipartition procedures, the SASE, and all these procedures. And this is my dear friend, Nicola Scopinaro, who taught me a lot of what I know now. And Nicola had a very strict follow-up for his patients with high malabsorptive procedures. He would follow up all his patients for life. And after he passed away, one of his fellows presented 45-year data of his patients that he follows all the time. And they said a lot of liver failures, a lot of malabsorptions, don't do it. Okay, this happens with very good follow-up. So what then happens with the bipartition? SASE procedure was invented as a technique to treat sleeve leaks. Okay, later it was used as a bariatric procedure with zero evidence, no science behind it. The bipartition concept was invented by Santoro. Do you guys know Santoro? Okay. Do you know the history of Santoro? The forgotten history of Santoro? Do you know the Santoro 1 operation? Santoro 1 operation, he devised an operation entailing sleeve gastrectomy and resecting half of the small intestine. Next morning, after dreaming about this procedure, he's doing it to teenagers. I have teenagers from Egypt, had this procedure with him. So he never did a standard procedure. He just invents procedures and does procedures and make up science for these procedures that he do. He has an 80 centimeters common channel. 80 centimeters with claimed benefits with nutritional preservation while maintaining hormone response and metabolic impact. SASE procedure, it lacks validation, and the published data is scarce, no long-term data, and we have only reports of 1 year outcomes, and there is a very widespread use for it in commercial bariatric metabolic surgery settings. And now we're starting to see reports of severe malabsorption outcomes in many countries in the Middle East after having the SASE in Egypt. Radiologic reports also shows progressive strictures of the anastomosis and closures of the anastomosis. So what is SASE? It's a sleeve gastrectomy with added unsupervised, unregulated, severe malabsorption performed in commercial setting without appropriate post-operative follow-up, and this is a recipe for disaster. And these are some of the papers now starting to surface in the Middle East about the severe malabsorption that follows these procedures. You become like what you worship. So logic-defying science is wrong, even if publications support it. So if you have somebody would tell you gastric pouches don't dilate, no, they will dilate. Sleeves and reflux, no problem, big problem. OAGB with no bile reflux, no anastomotic ulcers, no internal hernias, no, it happens. SASE with zero malabsorption, not true. So how to solve the problems? Commercial bariatric surgery should not change the scientific surgery rules. And governments should have strict supervision over the medical tourism practices and the use of single-use instruments. Patient awareness programs with education about experimental procedures. We need to educate the patients. Patients call me all the time and say, "Doctor, SASE is the best operation." Do you do SASE? And proper follow-up should be part of patient care in medical tourism. Substandard medical tourism services should be criminalized. The aim of argument should not be victory, it should be progress. Don't waste your time with explanations. People only hear what they want to hear. And hell is truth seen too late. Of course, Kosheri, everybody in Europe knows Kosheri. There are patients whom we cannot help, but there are none whom we cannot harm. So in conclusion, don't believe everything you're told. Surgical ethics should be the cornerstone of every metabolic bariatric surgery practice and every IFSU member. Surgeons should not aim only to reduce morbidity and mortality, but it's their duty to ensure the procedures they offer are safe, scientifically valid, and proven long-term efficiency. Unsupervised malabsorption is a recipe for disaster. Study the history, people, and current evidence behind the new technique before deciding using them in your practice. And hypoabsorptive procedures should not be practiced if the surgeon and patient are not committed for a lifetime follow-up. Medical tourism needs strict government supervision. A system for patient follow-up must be established, and our conflict of interest is the patient's well-being, not how much money we make. Thank you very much.
Thank you, Khalid. There is a lot to do in this respect, and I'm looking forward at the end of the session when we will discuss which will be the direction you you will guide us toward to do something, because it's so much to do and we need to do the first steps. Okay, let's listen for the last one.
Yes, the last talk is about economic perspective, impacts on health systems. Chetan Parmar from United Kingdom.
Thank you very much, the panel. Thank you all my previous speaker. You covered most of the topics, so my presentation kind of becomes easy because I'll probably repeat half of what you said. But I'm going to focus more on the economic perspective, the impacts on health systems. So I'm Chetan, one of the bariatric surgeons from London. These are my disclosures, probably nothing related to this talk. I missed the first to talk because I was presenting next door, so I don't really know how much was discussed, so pardon me for that. Just a brief idea on the global economics of medical tourism and why all of a sudden we can't just stop it, because it's a really big money market. Medical tourism, I think I saw Maria put that out, 400 billion per year tourism. Number of medical tourists around 14 to 16 million, and at least 2% of this is all bariatric procedures. And there is growth of compound annual growth of around 20% when it comes to medical tourism as well, out of which around 12% share is for bariatrics. So I don't think it's going to decrease, it's only going to increase. If you then look at the financial side of things, again, this is the global market. The light blue color there is the bariatric medical tourism. So if you look in 2022, it was only worth 9.7 billion, and that's projected to be around this big blue chunk in 2030. So again, it's only going to increase. And why is medical tourism? Again, I think you must have already discussed. We know it's complex, multifactorial phenomenon, and with the social media, easy air travel, hospital packages and all, it's going to only get easier and easier. But there are different types of medical tourism. I think one is this outbound, inbound, and intrabound. And I will touch on that later on. I mainly want to talk of a couple of things just from the UK perspective, why we have it. One is the long waiting list, and second is the cost. This is our IFSO global registry. If you notice our neighbors, France, 35,000, Chile or Germany, 26,000, Italy, 20,000. And look at UK, 7,000. It's even less this year, 6,000. So we are doing a lot less compared to our neighboring countries as well. Obviously, that contributes to a long waiting list. So you can't just blame the patient. The patient can't wait 2 years for just that. So they obviously will go and look for a better option. I think, again, someone showed this slide. Look at the cost. This is the paper we published by the IFSO survey we did in 2019, I think, post-pandemic. UK cost, around 15,000. Countries where they go, 5,000. The way Khalid presented, I think it must be 1,000. Yes, so it must be even less. So again, cost, waiting list, bit of background. So that means now let's look at the economic impact on the destination health system. Okay, so I'm going to do it at two. The country where they are going for tourism, and pardon me here, I'm going to kind of focus on Turkey, because for UK, Turkey is a big center, so no blame on it. There are good surgeons there as well, but to just make the talk easy. So I'll first do all the thumbs up, the positive for the destination country, why they would want to promote it. If you just go to and type health tourism, Health Turkey government official website comes up. If you just type here bariatric, this comes up. 196 hospitals on government Turkish website immediately comes up as recommended sites for bariatric tourism. Not just that, they have a 24-hour helpline. If you have any question, 7 days a week to solve any queries there as well. So the governments are promoting it. And we saw that it's a £1 billion industry. So let's go a bit in detail to just an example. Now I did take this slide from a Turkish French surgeon. This is just one of the, okay, the last bit of the slide is not visible. This is a 3-month data from so the Turkish sites promoting it. Also, all factors, they give you all the details. And here, 3 months of income from just one university, 350 overseas patients, 317 for appointments, I can't even count. This is, I think, millions, and 2.3 billion just for one country in that 3-month thing. So it's big money for the government as well. So that's the economy benefit for the government there. So do you think you can just, me or you talking or some guidelines from IPSO will stop it? No, there is no way anybody is going to care about these things. It's big money, guys. Yeah. With this, obviously, is the promotion of healthcare. That's again on their tourism website. If you look, it promotes this. And if you look again there as well, they're just from the tourism, not directly associated with bariatric medical tourism, just the tourism is 9.8 billion. And I think somebody mentioned earlier that people go there, they get free hotel package, beach, all-inclusive resorts and all. So big chunk of money. What are the downside for the country where the destination or the patients are going? Very briefly again, these are the number of patients they are seeing of overseas. And I have not highlighted, for example, in Turkey, I'm told that they are not in the registry, but I'm told they did 80,000 bariatric procedures last year. That's a lot, okay? And I think they did more bariatric surgery of UK nationals than what UK nationals did in UK. Okay, so that again gives you a bit of a picture. So what are the downside here? Internal brain drain. And what I mean by that is, like Khaled mentioned, lot of money involved. So maybe the clever surgeons or good surgeons or whoever, rather than serving in the public sector, they tend to open their private hospitals and focus on the private side of things as well. What does that happen? We don't know. Does that mean the quality of surgeons or so in the public sector get compromised, or the ethics of the surgeon gets compromised because they are more focused in just operating in the private sector and making the money like you mentioned? And does that lead to poor standard of care? What we already looked at, that it then becomes a competition. Healthy competition is good, but we don't know what sort of competition this is. Like again Khaled mentioned, you then have to drop your package, 500, 400, poor quality. So that all affects somehow or the other the economy side of things as well. I'm not touching on the patient side at all. I'm ignoring the patient side just for this talk, just the economics. And the problem then is, how do you regulate them? Some of the surgeons in these countries I have asked, they are not even part of their national society. So there is no way to control or regulate. Yes, again, we can talk of things, but they are just not members of the society. The message never goes to them. And that's why they are not accountable. And therefore, there is no transparency. So these are all the downsides for the economy for where this happens. Now, the economy on the country of the origin where the patients have come. This was the poster we published in 2017 in IFSO, where we first actually started having experience with medical tourism in London. And what are the downsides for us here? I'll just go into detail here. So like I say, a lot of countries where the patient came from, different procedures around. This is what was important. We looked at 35 patients and we found that majority of the patient actually, if they were not eligible for bariatric surgery in our parent country. From the economy side of things, yes, that doesn't matter much, but what happens? When they come back, or the other cohort of patients, they are upset that we are not doing surgery on them, whereas in other countries they are getting surgery just like that. And they kind of find blame in the system, which leads to patient complaints, which leads to angry team, mental well-being, and again, I think Maria mentioned on the off-sickness or the mental health. So that affects again the economy side of the team and the broader economy side as well. We broke down the complication and looked at from the UK perspective, and we found that for every complicated patient we had, the patient had 22 days of inpatient admission. We do bariatric surgery today, they go home next day. So instead of a one-night stay, 22 extra days they were staying in the hospital, which again has a big economic impact. Multiply those by the number of patients and all. In UK, last year, we had the first time, here, look, 24-hour patient were just waiting in A&E on the trolley because there were no hospital bed, to the extent that the government has now actually published a guidelines for A&E corridor care, and they are appointed new nurses called A&E corridor nurses. Shocking, right? Well, it's happening. How does it affect the cost? Each patient, this is just a very kind of low number, 16,000 additional cost because this is how it costs. So that's again huge money, whereas it would only cost 2,000 or so primarily. What that leads to? This. The government has to say we had 25 British nationals who died because of medical tourism. And every day we had this news. Every day, reckless surgery, reckless surgery, reckless surgery. How does it affect the economy? Well, we anyways are struggling with stigma and all. Patients lose faith in bariatric surgery. So that's another challenge. Then you have to, then with more obesity, more unemployment, and those factors on. How does it help the economy? Maybe a little bit, with maybe helping reducing the wait list, some reducing pressure of the healthcare system, maybe more options for the patient, and again, maybe some patients just go to a foreign country because they want to avoid that stigma in that society there. So those are probably the some advantages which the patients tell us motivates them. How to deal with this, I won't go in detail, I think, but this paper was already quoted twice. But yes, as IFSO society, we can't just blame the patients. Probably we have to take some responsibility and try to pass those messages out there and things. And main thing is try to do something, raise awareness as much as possible. This is the discharge summary I get with my patient walking. You translate and the only word you find is gastric bypass. So you have no clue what is done. Patient comes and says, I have a gastric band. You scope, it's mini bypass. Again, with a short pouch. So anything, it's just full of surprises. You do a CT scan and you find funny things there. So again, to address that, what we have done is, we've just published, just like the WHO safety checklist, we have published a discharge planning safety checklist in simple, basic English. We have sent it to Turkish surgeons, to Mexican surgeons. Also, we have sent it to all public patients group as well, like the ECPO and UKCPO, so that the patient can take this one page and go to the surgeon. So if he goes to, say, Egypt or somewhere and say, can you just fill this up? So at least when he comes to me, I know whatever patient had a bypass and what was the Pilimon Erimel, something basic. And that's why we kept it very basic English. Obviously, this paper was quoted as well. So we have now come up with the IFSO-EC, IASO, and the ECPO guidelines. So please have a look at it. It's from 24 countries representative, 119 healthcare professionals, and it has a list of things. We again have proposed and written to the Prime Minister to see whether we can increase our bariatric surgery numbers, to see whether patients get facilitated. So maybe all national societies should do that. So to conclude, can we stop it? I don't think so. So the only idea is to then make it safe. And I think Khaled already touched on it. Yes, economics of both sides are affected. Follow the IFSO guidelines, maybe get proper documentations and have accredited centers so that we know there are reliable doctors surging. And the best thing probably is to have a tourism registry so that we know what's actually having with this. Because it is possible that 99 patients might be doing well and one patient is complicated, which we see, or it might be other way around, that 80 are well and 20 are bad. But unless we have a registry, we just won't know. So that would be a start to know. So thank you, guys.
So that concludes the lectures on the topic, and I invite you to sit in front here, and I'm sure that there will be a lot of questions. So we started with addressing the motivation going out anywhere outside the country. Then we discussed about safety, and it was addressed by the French colleague. Then we discussed about the ethics, where we are not offering enough to our patients, the global and regional perspective by our president, and we started also the topic on the frame of medical tourism, and then we end up with the economics. So we see how complex is this scenario, and we used to point out the others they are responsible for it. So that's the surgeons that are performing different operations to the patients are responsible for what is exactly the consequences of medical tourism, but we should look carefully to what we can offer to our patients. So questions in this respect, if there are any questions. Yes, Nick, please.
I'm interested in the patient personality who does this, because as we've heard at other sessions, one of the biggest barriers to people wanting to have metabolic bariatric surgery is safety. And yet they're happy to go to these centres where they, re-sterilize equipment, they have shorter follow-up. So, in your discussions, do you ever ask them, why did you go? I mean, a lot of people are saying cost, but there just seems to be a huge difference. And the other thing is, I'll just make a point. I'm not a surgeon, I'm an endocrinologist. I can tell you in Australia, in gymnasiums and other places, the retatrutide, which hasn't even completed phase 3 clinical trials, you can buy copies of that in the gymnasium for $100. So this is almost becoming not just tourism for surgery, but medical, and maybe that's one of the things that's going to undercut. But this is amazing, just the differences. And one of the other things that patients will say to me is that one of the reasons I'm considering this is I can have bariatric surgery and at the same time have enough money for my skin reduction surgery. So that's one of the issues, because they say if I just pay for the bariatric surgery, then I'm left with this skin. I wish I didn't do the surgery, but I can have 2 for 1. So just a few comments. And
yeah, thank you very much for addressing this. So that's, I'm inviting you to answer. And you touched the point of follow-up. Let's be honest and look at the follow-up programs in the countries from where these patients are coming. Because the follow-up is pretty, let's say, modest in the countries, in the majority, let's see, to the big picture. And the surgical performance, I can tell you that with these volumes, 20 a day, the surgical procedure is not in a bad shape, because they are doing the same thing in several times per day, tens per day, maybe more, and the performance is not that bad. So I am somehow voicing which is their position. And if you are increasing the filter, as you do, a very nice certificate for the patients, if you are qualified for my program, please answer correctly to all those questions, maybe they will give up and they will go somewhere because they are getting a lot of invitations from their mobile phone. So that's just mentioning bariatric surgery or weight loss or anything, and then there will be bunches of invitations to something that it's hidden behind beaches and hotel and limousines, and then it's sassy behind, but they don't know anything what's happening.
I think the major problem with the patients nowadays, they don't look for safety, and the most dangerous thing is the Google doctor effect. So they go browse and read and think they are experienced enough, that they are qualified to take a decision. So you have a guy with a severe reflux and he wants a sleeve gastrectomy. And then he would tell you, no, this is the best, I'm not getting otherwise. So to correct this, we need to make good patient awareness campaigns to tell them that this is wrong. So in Egypt, I tell the patients, if you don't see the surgeon, this surgeon that does 40 cases per day, he has he's a junior surgeon, but he has 5 junior surgeons preparing the field for him. So all what he does is just do the firing, then go to the other room, do the firing. So it's not a good, and it's all relaxed sleeves to have less complications. So the patient, we need to make them aware that sometimes what they see is wrong and it's not always what they think of.
I think the patients are not seeing where is the compromise. They are getting the invitation because it's a very low price. And there is, no matter which operation, you can say gastric bypass or gastric sleeve, but they are not comparing apple with
exactly.
So they are saying, okay, I can buy a sleeve with this price, what should be the difference?
That's what they do in the private sector anyway.
But
Anywhere.
yeah, that's everywhere.
Being very
So that's
Yeah.
obviously.
But you know,
Obviously
in marketing, there's a rule that
Yeah,
when
that's
if you
a-
go into price wars, everybody loses, except the customer. But
So-
here, in the case of bariatric surgery, the customer is the biggest loser because it's not the same quality. So if
Yeah,
you have
the
the same
customer is
commodity,
not
the same
aware
price,
because
yes, but it's
obviously
not the
we
same.
cannot influence somehow those providers. I mean, the performers will be there. They are not listening to what we are talking here.
Yeah, it has to be a government
Never.
body
It
that would
should be
impose
someone
on
above
them what to do.
which is how we can get to them. And I think that it's a very good idea to go to the patients, and the patients might ask for a minimal requirement at the end of the information. They're like a passport of what had happened there. This can be an idea.
Hi.
Please.
So I'm a GP from the UK, so I see quite a lot of people in there, people there thinking about going, and I have a conversation with them, basically warning them about the risks. And in answer to your question, I think it's really variable. Some patients are really careful, they do their due diligence, do a lot of research, other people don't. And in terms of why they are, people are seriously concerned about their deteriorating health because of the waiting list. So for them, it's a balance between my deteriorating health and the potential risk of surgery, and they make the choice about their deteriorating health because that's their biggest concern. So I think, as everything, it's complex, it's very individualized, but I think some people are making what they think is the right decision for their health at the end of the day, whatever the risks are.
So we have to do something to inform more the patients. Are they validating their decision with you as GP or not with any of the surgeons? I mean, because if they are calling you, they will get the right answer.
I think if they ask a GP or a surgeon, at least this is just a UK example I'm giving, then we obviously say no. But that's exactly what Helen probably is also touching to, the waiting list. In UK, if I decide today to have bariatric surgery and I start approaching the doctor, my bariatric surgery will happen in 3 years' time.
If you're lucky.
Correct.
Oh, in
So
Nova Scotia,
that
my
means-
kids live in Nova Scotia, and it's a 10-year waiting list for a sleeve extraction. That's even more than the half-life of the procedure.
That's true.
So it's much good saving.
Can we learn something from these models? Can we, in our countries, learn something to improve something in our institutions, to be more efficient? I'm not saying offering limousines.
But I think the other issue is,
So remember, we
Yeah.
all have been discussing in the thing that we are only operating on 1 or 2% of the patients.
So that's
It
a
just means
room
we
to improve.
operate on larger volume safely. Once you have that larger volume, you would be able to, have a standard procedure where you would be able to run 3 theaters and do it. Whereas in UK, one sneeze from the patient and the whole hospital stops. Bariatric surgeries are cancelled for a month. So you can't work with this model and then blame the patient. So
Yeah.
we have to also look at ourselves first. That there are a lot of things we can improve as a government, hospital.
So it's again governmental decision, as Khalid said. It was both ways, to regulate the medical tourism and improve what we can offer to our patients to improve the access.
But at the end, how can you control if you have a relaxed sleeve versus a good sleeve? That's uncontrollable. How would the patient know the outcome of the center they are working in if it's all fake data and fake news?
And that is the other problem, what I realized, that some of the surgeons are not even registered with any national society. So there is no way to even regulate them or tell them what to do. They will just do whatever way.
Oh, let me give you the worst news ever. We have non-surgeons, non-doctors doing
Yeah.
sleeves in Egypt.
Yeah, but that's
sorry,
well,
I was
that's a
just gonna
worst
say,
scenario. Please.
The other thing is that I can say don't do this. It's the risks, but at the end of the day, patients listen more to social media than they do to us nowadays. So we have to be really aware of that and get wise about it. So the UK government has actually started doing some work through social media to try and help with that. You need to be on Instagram, etc. That's where people get their information nowadays.
Yeah,
And
but
that's what they believe, what
looking
they
to the
believe are
numbers
suspicions.
that were presented here by Chitin, I think they are making a lot of savings because out of maybe 100 million pounds, they are paying 1, 2 million, 3 million, 5 million for the complications, but yet the rest is saving. And it's, put it in another way.
Yeah.
Please.
Can I just make a suggestion? I'm on the board of the only consumer advocacy group in Australia, and I know there are throughout the world. I've been in this space for 25 years. I've learnt a lot listening to you all today. I would put it to you that each country needs to speak to their consumer advocacy groups, because as the previous speaker said, patients trust patients sometimes more than they trust us. So I think that's a very good way of getting the message out there. What you said, Khalid, and the others about re-sterilisation, about junior doctors, you know, if you go along and it doesn't appear as though you're advertising for yourself and they trust you, they get the message out. So as soon as I go back to Australia, I'll be telling my association about, you know, the dangers of medical tourism. And I think that's a very powerful tool.
Yeah, agree. Please. The last point here, because we are at the end of this very interesting session.
Thank you very much. I am 15 years more in the Middle East, so in Dubai. And we had patients coming back from Jordan because they were sent 40 patients per day. Next day they are placed on the plane and they were delivered back to where they came. But I want to say that we have different perspectives. Here we are talking about MENAC a little bit, and we are in IFSO European chapter. This is really, because in Europe we must acknowledge we have better regulation and better quality standards, and the patients can complain, I mean, and really a regulatory level is much higher. I completely agree that in the countries like this, in Middle East, yes, or at,
patients from Europe.
yeah, I know. Yes, absolutely. But for instance, in Turkey, they are a little bit of the on the other level because they have more of regulation. So this is also we need to understand. Yes, these are different countries where we are getting the patients. So this is one. But two, we are now putting a little bit of blame on the patients or leaving for them. But we have to fix our systems. Because Çağatay's saying they do 6,000 surgeries. I asked, preparing my presentation, asked the Turkey. They done last year 90,000 surgeries. From those 90,000, it was 30,000 medical tourism, and majority were British people.
Yeah.
Majority. So you think they have done 5 times more that you are doing in UK. So this is, we can talk a lot, you know, and say patient, whatever, but we must really look in Spain, UK, Ireland, other countries where even Serbia, they say, okay, there a lot of patients are going from Serbia to Turkey. So this is, but they do not have a good reimbursement also in the place. So at least Europe, I think, is very much more social.
Yeah, that's, yeah.
Okay.
Please stand up, please. Would you finish, please?
Yes, yes. So what I want to say, there is no other region in the world that's social that Europe. Yes, where
here's the paradise.
Yes, it's in comparison. In comparison, I mean, and we are really living, and we must. If you travel around, or at least you work around, you start understanding how good is here, but how much work still we have to do. And this is, if we are thinking about patients living with obesity, and really it's about a stigma. Why UK government is not giving, you know, these damned a few millions more to have these 15,000 patients operated?
You are right. Let's see what we can do now. I mean, there will be one step at the time, and probably focusing the patient's safety, because it's on our hands. Trying to stimulate them to ask to those providers a minimum list of what has been done, and then it will be like a passport. It was that very operation, because they got lost always.
Also push our government.
Yeah. Who will do this? In each country, we take the message to do this. Okay, that's,
yes,
I think
we
it's
can
a
do,
good
but
conclusion.
I know very well Almantas. He is a friend of mine. He's a great guy, and he traveled a lot. He educated a lot of surgeons. He knows situation Europe-wide. And then in Serbia, I think we can make a parallel between bariatric surgery and, let's say, orthopedics. In orthopedics, we have a great number of patients waiting for the operation. There is no way, no manpower, no hospital power to overcome the people need the operation. And I was speaking to my friends that are orthopedic surgeons, very successful ones, and I was asking, okay, you don't care about waiting list, because waiting list means a lot of money for you in private hospital. There is no interest in, you are not interested in reducing the waiting list in public hospital. And he said, yeah, you're right, because I have so many operations private. And the only way to overcome that is the government to reimburse the cost of material we used, and then they can give to private hospital, they say, okay, we have waiting list, you can operate on them whenever you like, we will reimburse the money, and then the private clinics will compete for the price of the doctors.
Yeah, you are right. That's increasing or improving the access in those very countries. And it was addressed from the very beginning in the first talk. So there is a lot to do in this respect. I'm time cautious, so I would like to thank you very much for this session and the energy that you are living with. Thank you very much for you to organizing here. Let's do a picture.